The presentation seen while I'm presenting?
Yes, sir. We are live, sir, and starting off now. Good evening, everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome you all, the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, let me welcome our very renowned Lieutenant General Dr. C.S. Narayana. Sir is MBBS MD Medicine, DM Neurology, Chairman of Manipal Institute of Neuroscience, Delhi. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is organic brain lesion presenting a psychiatric illness, case-based learning. Now, without any further delay, I would like to welcome Sir again at our forum and would like to hand over the session to him. Over to you, sir.
Thank you so much for the kind introduction. So the topic for today is organic brain lesions presenting with psychiatric symptoms. Greetings from Manipal Hospitals, where I chair the Neurosciences Department in New Delhi. The overview and objectives of today's presentation are, firstly, to understand how brain lesions can mimic psychiatric illnesses, to explore the overlap between neurology and psychiatry, which is a very important facet. Thereafter, to review the neuroanatomical circuits involved in psychiatric symptoms, with a focus on frontal, temporal, limbic, and subcortical structures. Thereafter, we'll identify major clinical syndromes with psychiatric presentations, like mood disorders, psychosis, anxiety, and personality changes. Thereafter, we'll dwell a little bit on the diagnostics tools which are available at our disposal for evaluating organic causes like imaging, EEG, CSF, and serology. A little discussion on treatment strategies which address lesions and manage psychiatric symptoms. Most importantly, we'll highlight red flags for organic etiology in psychiatry, like late onset atypical features and resistance to treatment. Firstly, a small note on the historical perspective on the connection between neurology and psychiatry. This has existed almost from the 19th century, where pioneers like Charcot, Kraepelin linked brain and behavior. This got lost somewhere along the way in the early 20th century, but in the 21st century, there's been a re-emergence of biological psychiatry driven by imaging and molecular diagnostics. Thereafter, neuroimmunology and connectomics have deepened our understanding, with links between autoimmunity and psychiatric illness being firmly established. Now, we all know that multidisciplinary neuropsychiatry is very essential for the management of these patients. So, what are these organic brain lesions that we are talking about? Both structural and functional brain abnormalities like tumors, strokes, infections, inflammation, and trauma can present with psychiatric manifestations. And these psychiatric manifestations may either precede or follow overt neurological deficits. I must clearly understand that so that we do not make any mistakes. And these neurological syndromes can mimic any primary psychiatric illness like depression, mania, psychosis, and personality change. And they are often resistant to standard psychiatric treatment. The treatment response may be poor, or paradoxical responses should also raise suspicion. We require a targeted evaluation for the underlying cause with imaging, EEG, labs, and neuropsychological testing, and early identification improves the prognosis in all these patients. Now, like I said, we'll focus on some of the syndromes with problems in the brain. Like the first one that we'll be talking about is the frontal lobe syndromes. We're all familiar, but I'll kind of like to re-emphasize some of these very important syndromes which present with psychiatric manifestations. Firstly, the dorsolateral prefrontal cortex. This impacts executive function, leading to poor planning and apathy. Orbitofrontal cortex damage causes disinhibition, impulsivity, and emotional lability. Whereas medial prefrontal cortex syndromes cause abulia, lack of motivation, and social withdrawal. And anterior cingulate involvement effects cause a flattening of the effect and loss of initiative. So as we see, a combination of these syndromes may actually mimic depression or schizophrenia and may lead to misdiagnosis and also mistreatment of these patients for a very long time. Frontal lobe syndromes are also associated with poor insight and treatment compliance, and they may also reduce self-awareness. So we must be very clear in our understanding of the basic pathologies of frontal lobe syndromes. Next, we will dwell upon some of the temporal lobe pathologies. Mesial temporal involvement, like we're all familiar with mesial temporal sclerosis, can cause memory loss, complex partial seizures, and paranoid ideation. Amygdala hyperactivity can cause fear, aggression, and emotional instability. The left temporal cortex observes auditory hallucination and thought disorders. Temporal lobe epilepsy can manifest with interictal psychosis and hyperreligiosity. Right temporal lesions can cause delusional misidentification and visual hallucinations. And this complex of symptoms can also be misdiagnosed as schizophrenia. And if we do not diagnose the organic pathology behind these symptoms, we will see that the response to treatment with antipsychotics is very poor. Now we come to parietal and occipital lesions. Right parietal damage can cause neglect and misidentification syndromes. Bilateral parietal lesions can cause acalculia, apraxia, and this combination is called Gerstmann syndrome. Occipital cortex involvement can cause visual hallucination and cortical blindness. Anton syndrome means denial of blindness, and this can be misinterpreted as psychosis. So, occipital lesions are an important differential diagnosis for visual hallucinations, but we see that insight is preserved in these patients. An important component of organic lesions is the involvement of subcortical structures like the basal ganglia, and involvement of these structures can cause OCD-like symptoms, tics, and affective lability. Thalamic lesions can cause apathy, disorientation, and impaired consciousness. Hypothalamus observes sleep, appetite, and there's a complex interplay between endocrine and psychiatric syndromes. Caudate nucleus involvement causes impulsivity, stereotypies, and cognitive decline. So these subcortical structure involvement is very common in Wilson's disease and Huntington's disease, wherein the psychiatric symptoms can precede the movement disorder by several months and even years. In all these syndromes, dopaminergic dysregulation plays an important role, and they may explain the psychosis, mood symptoms in these kind of patients. As we all know, the limbic system is a very important component in psychiatry, but they can also be affected by organic lesions. The hippocampus is involved in declarative memory deficits, wherein the patient can have confabulation and anterograde amnesia. The amygdala, like we have said earlier, plays a role in fear processing and aggression. The cingulate gyrus is for emotional processing. Limbic encephalitis can be of autoimmune origin and can present with mood swings, hallucination, and catatonia. Structural disruption of these structures can cause affective syndromes, and they can be seen in some organic disorders like trauma, tumors, and sclerosis. So, what are the mood disorders with an organic basis? Depression is very common post-stroke in Parkinson's disease and in multiple sclerosis, and this can be attributed both to lesion location or inflammatory mechanisms. Right-sided lesions of the brain may trigger mania with irritability, euphoria, and poor judgment. Frontal and basal ganglia involvement cause disruption of the frontostriatal thalamic loops, and they may not respond very well to typical antidepressants. Bipolar features may arise in neurodegenerative disease like Huntington's, Wilson's disease, and frontotemporal dementia. Psychosis can also be of organic origin. Delusions and hallucinations from temporal and limbic lesions. Visual hallucinations, as we said, can be present in occipital lesions. Acute onset and fluctuation of psychiatric symptoms suggest delirium. So in these kind of patients, it's important to rule out toxic and metabolic causes. Paranoid psychosis can be seen in right temporal disease. Organic psychosis may lack formal thought disorders, which are a characteristic feature of psychiatric disorders. In all these conditions, antipsychotics may actually worsen the condition, particularly if epilepsy is present. Anxiety and panic disorders can also be a manifestation of organic brain disorders. Temporal lobe hyperactivity can be linked with panic disorder. Hypothalamic and limbic dysregulation can cause dysautonomia and fear responses that may be amplified. A post-traumatic stress disorder-like feature can be present in limbic encephalitis, wherein the patient has got flashbacks, hyperarousal, and irritability. OCD in basal ganglia orbitofrontal pathology is not uncommon, and they can manifest with tics, compulsions, and intrusive thoughts. Anxiety may also be secondary to awareness of deficits, which is a characteristic feature in the early phases of neurodegenerative diseases. Organic anxiety is often resistant to cognitive behavioral therapy alone. Patients with organic brain disorders can also have personality changes and disinhibition. As we have already said earlier, orbitofrontal disease can cause inappropriate social behavior with disinhibition, irritability, and tactlessness. Right frontal lesions can be linked with a loss of empathy, and they can have acquired sociopathy. Temporal lobe epilepsy may cause hyperreligiosity, also hypergraphia, and altered libido. Frontal lobe syndromes mimic borderline or antisocial traits, and they affect regulation and impulsivity. Head trauma is the most common antecedent to these personality changes, and they can be present even when there are no changes on the MRI. Cognitive and executive dysfunction, we've also said this earlier, can be present in frontal, thalamic, and subcortical lesions, wherein there is a disorder of planning, sequencing, and set shifting, and these may be impaired. This combination of symptoms can mimic depressive pseudodementia, especially with apathy and slowness. They are differentiated from poor effort and variable attention on neuropsychological testing. Executive dysfunction is a very common characteristic of white matter disease, and they are very common in those with vascular cognitive impairment. So these subtle findings may precede a diagnosis of dementia, where early intervention is critical. As I've said, delirium and acute confusional states are very common in neurology practice, and the important characteristic is loss of attention, and they have an acute onset with fluctuating levels of consciousness. So these are often the first sign of a brain insult. These can happen with infections, metabolic disorders, and toxic causes, and these also always must be ruled out before we make a diagnosis of a psychiatric illness. Psychotic symptoms are also common in delirium, but they're very transient. And the most important features are visual hallucination and disorganized speech. The EEG in these patients may show diffuse slowing and poor attention, disorientation, or hallmark signs which must not be missed. Delirium is a medical emergency and must not be confused with a psychiatric illness. We'll talk about some specific disorders which are increasingly being identified in practice. One common disorder is autoimmune encephalitis. It has been said that autoimmune encephalitis is as frequent, if not more frequent, than viral encephalitis in practice these days. NMDA receptor encephalitis can present with psychosis. It affects young females who present with seizures, catatonia, and movement disorders. They may have other types of autoimmune encephalitis include antibodies against neuronal cell surface proteins like AMPA, GABA B, and LG1. MRI may be normal in these patients, or they may show limbic signal changes. CSF may not show pleocytosis and oligoclonal bands. So these patients have a rapid onset of behavioral and cognitive symptoms with hallucinations, aggression, and paranoia. They are often misdiagnosed as schizophrenia initially. However, if one is very alert and diagnoses the condition properly in correct time, it improves outcomes tremendously with immunotherapy like steroids, IVIG, and plasmapheresis. Another important organic cause of psychiatric symptoms are infectious disorders. Neurosyphilis and HIV both have become relatively uncommon but still seen in practice, and these present with psychiatric symptoms, especially in the late stages when they are untreated for a very long time. Herpes simplex encephalitis characteristically affects the temporal lobes and can cause hallucination, memory loss, and seizures. In our country, we always encounter patients with CNS tuberculosis, and cryptococcal meningitis is very common in immunosuppressed patients. These patients may present with mood and psychotic symptoms. PML, which is very common these days when we exhibit immunosuppressants for the therapy of autoimmune disorders like multiple sclerosis. These patients can have cognitive and personality change. The diagnosis of these patients is with CSF PCR and neuroimaging. Traumatic brain injury, as we said, is a very common cause of psychiatric manifestations, particularly because they affect the frontal lobes quite commonly, wherein the frontal lobe kind of hits against the tentorium, and also they can have contra-coup injuries involving the occipital lobe. So the anterior frontal and the temporal lobes are commonly affected, and we have told you about the symptoms of irritability, impulsivity, and apathy with these symptoms, with these structures being involved. Chronic traumatic encephalopathy can present with depression, aggression, suicidality in athletes, particularly in boxers. Post-concussion syndrome includes mood lability, and they may persist even after minor head injury, which may not be picked up on imaging. TBI patients are at increased risk of psychosis, especially in those with a prior psychiatric history. As I have said earlier, structural imaging often fails to show micro-injury. Diffuser tensor imaging or a functional MRI may be more sensitive in these patients. Another common cause is the presence of neoplastic lesions of the brain, like tumors in the frontal and temporal regions, meningiomas, gliomas, pituitary adenomas, which can cause hormonal dysregulation. And in all these patients, psychiatric symptoms may precede the neurologic signs. And these patients have a progressive course, and their refractory response to conventional therapies, depressants or antipsychotics, may suggest the presence of a tumor. So we must take recourse to early imaging in all patients where we suspect an underlying organic cause. The blood vessels in the brain do not fall far behind, and they contribute significantly to psychiatric manifestations. Small vessel disease can cause executive dysfunction, wherein they present with subcortical dementia, with apathy and depression. Strategic infarcts in the thalamus and the basal ganglia can trigger mania and psychosis. So this is a very important aspect where we even a focal lesion can present with psychiatric manifestations. Multiple strokes may mimic schizophrenia, where there is emotional dysregulation and paranoid ideation. Frontal subcortical circuits are highly vulnerable, and they can cause mood when these centers are affected, mood changes when these centers are affected. So, to summarize, what is a common organic diagnosis presented with psychiatric symptoms? You can have brain tumors in the frontal, temporal, limbic regions causing personality change, depression, psychosis. We can have autoimmune encephalitis and other infectious etiologies. We can have epileptic lesions. We can have neurodegenerative disorders like frontotemporal dementia, Parkinson's disease, and Huntington's disease. We have already talked about other CNS infections like tuberculosis and cryptococcal meningitis, and both small vessel disease and strategic infarcts as far as the blood vessels are concerned. One small word about the pediatric and adolescent population. When the person has got early onset of psychiatric symptoms, we must screen for neurodevelopmental and metabolic causes. This is very important. Rather than taking recourse to treatment with psychoactive medication, these patients will always be screened for these disorders. They may have pandas and Sydenham's chorea, presenting with OCD, tics, and behavioral regression. They may have inborn errors of metabolism, like the urea cycle disorders and mitochondrial disorders. They may have autoimmune and demyelinating conditions which do not exempt the pediatric population, like NMDA, encephalitis, and multiple sclerosis. And early intervention in these patients is crucial to correct diagnosis. Now, a word about elderly patients. Late onset psychiatric illness is often organic. You must always remember that. And they often present with cognitive decline. And common etiologies include dementia, cerebrovascular disease, and most importantly, the side effects of some of the medications like hypnotics and sedatives. Polypharmacy and drug toxicity is also very common as a presentation with psychiatric disorders. And I would say that the most important culprit is the random use of anticholinergic in this elderly population group. Benzodiazepine for sleep disorders can also wreak havoc. Depression may mask early dementia, and it requires careful follow-up. As I've said, delirium is an important diagnosis not to miss. I've already spoken a few words about autoimmune encephalitis, and just to re-emphasize this concept, anti-NMDA receptor encephalitis, LG1, GABA-B, Caspar-2 antibodies can also present with psychiatric manifestation. The red flags in these patients, which one must always consider, is there subacute presentations with seizures, autonomic instability, and they decline rapidly over days to weeks. And they may often be misdiagnosed in the early stages of functional disorder. CSF and antibody testing confirms the diagnosis, and they respond very well to immunotherapy. So what differentiates functional disorders from organic disorders? Functional disorders, meaning they are primarily psychiatric, have normal imaging, normal other neurological tests. They may have psychological stressors, and they're often very chronic. On the other hand, organic disorders with a primary neurological problem, that is a structural basis to these symptoms, may have focal neurological signs. They have abnormalities in neurological testing. They can present suddenly, and they are age atypical. Conversion disorders can mimic lesions of the brain and they require inclusion of organicity. In all these patients, even those with functional disorders, clear empathetic communication is vital to avoid stigma while ensuring thorough medical checkup. Two small cases, one with a frontal meningioma, a 55-year-old patient with new onset disinhibition and apathy was initially treated as depression. There was a poor response to antidepressant. On imaging, the CT scan showed a frontal mass. Surgical resection of this tumor led to an improvement of symptoms with insight and judgment being restored. So this emphasized the importance of imaging in late onset illness. Second study is NMDA receptor encephalitis, which I said is very common. I have seen at least a dozen cases in the last 1 year. So here was a 23-year-old female who presented with acute psychosis and agitation. There was rapid progression to catatonia and mutism. The EEG showed diffuse slowing. The MRI was normal. So we must know that MRI can be normal in these patients. However, examination of the CSF showed positive NMDA receptor antibodies, and the patient responded beautifully to steroids and IVIG. So these patients must have an imaging and early CSF analysis. So the management principles for organic brain syndromes are treat the underlying cause, whether it is a tumor, infection, inflammation, or a seizure. We also must treat the psychiatric manifestations with antipsychotic, antidepressants, but they must be used with caution because some of them may aggravate the underlying organic cause. There must be a very strict multidisciplinary approach with cooperation with neurologists, psychiatrists, and neuropsychologists. Side effects and interactions between drugs must be monitored frequently, especially when the patient has got organic brain disease. Rehabilitation and caregiver support is very important. So there should be a shared understanding of brain behavior relationship. There should be a joint evaluation and round, and referral pathways are very important for red flag cases. So to conclude, the summary and take-home points: many psychiatric syndromes have organic underpinnings. Late onset, atypical and resistant cases require workup. Frontal, temporal, and limbic lesions are often implicated. Imaging, EEG, lab, and CSF are acute with diagnosis. Treat both the underlying organic disorder and the psychiatric symptoms. Collaborative neuropsychiatry enhances outcomes. Common pitfalls are assuming that the primary psychiatric illness in the elderly, ignoring subtle neurological signs, delaying imaging or referral to a specialist, and over-reliance on symptom scales without context. The last slide. This is a very important slide. The important red flags are age above 50, rapid onset of psychiatric symptoms or a change in their symptomatology, the presence of neurological symptoms, the presence of an underlying systemic disease, or atypical response to treatment. Thank you. I conclude here and would be happy to take a few questions.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yeah, sure.
So, sir, the first question is, how do EEG findings aid in differentiating seizures related psychiatric manifestations from primary psychiatric disorders?
Yeah, in primary psychiatric disorders, EEG is essentially normal in most of the disorders, like mood disorders, psychosis, though the incidence of borderline abnormalities is more in these patients, but specific abnormalities like what we see like temporal spikes in either mesial temporal sclerosis or herpes simplex and encephalitis, where there are these periodic lateralized epileptiform discharges. These are not common. And when there are organic brain disorders, diffuse slowing or asymmetric slowing in one hemisphere are very common, and these are not present in psychiatric disorders.
Next, sir, we have in a patient with depressive syndromes and new onset headache, what is your diagnostic approach?
Yeah, like I've said, when the patient has got depression, or when there are red flags, like in this patient, you say the patient has got headache. So that should be definitely red flag warranting further evaluation. And I told you the primary tools that we have are neuroimaging. We can screen very quickly with a CD scan, and obviously an MRI is much better. And when suspected, when we are suspecting a CNS infection or an autoimmune encephalitis, we must take recourse to a CSF analysis. In some of these patients, particularly, the EEG can be helpful. Like I've already said, they can have spikes which are related to one part of the brain, that is, they are focal onset spikes. There can be asymmetric slowing of one part of the brain, and also a thorough neurological examination, it goes without saying, is very important in all these patients.
So there's one last question. How how should treatment prioritize be decided between addressing the lesion and managing psychiatric symptoms?
So obviously, when there is an organic brain syndrome, that takes precedence over the psychiatric manifestations. And as you said, management of the organic brain syndromes, like I've amplified in one of the examples, like the patient got a meningioma. If you remove the meningioma, the psychiatric symptoms also get better. But while we are doing all that, as a temporary kind of measure, we can also give some medications to address the psychiatric symptoms.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, any take-home message from your end?
Yeah, as I've said, firstly, it's a pleasure to interact with the ICJP team, and also to address an audience of this magnitude and try to educate them on some of the important facets of medicine. Today, I spoke about the interface between organic brain lesion and psychiatry, and it is very important, a very important concept, and there should be a very close collaboration with neurologists and psychiatrists so that we achieve the most optimal outcomes.
Thank you so much, sir, for joining us today. It's our pleasure to have you here. Thank you so much, sir. With your permission, I
Thank
would like
you.
to
Thank
thank you,
you.
sir.
Good night.
Good night, sir.